Hey everybody, welcome to another edition of the AFR EMS case studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire Rescue. And today we are joined by our Medical Director, Dr. Kim Pruitt.
Morning, Chief.
And one of our esteemed 7/8s, Captain Jesse Murphy.
Morning, Chief.
Well, good morning, welcome. We're going to pivot a little bit today in regards of not talking about a specific case, but more covering a topic that is prevalent in the 7/8 role for sure. But it affects a lot of our frontline crews because it's something that we have to unfortunately do regularly, which is death notification. So for those who are watching who don't know, our 7/8s, our quality assurance captain, which Captain Murphy fills the role of on one of our shifts, responds to all the high acuity calls, all cardiac arrests, serves in a supervisory role, and assists crews with their treatment and decision making, and basically a sounding board for everything that the crews need, a great resource. One of the pivotal roles within the 7/8 is to handle a lot of the death notifications. Crews have been working for a long time. They're focused on care. You can kind of step back and focus on family and talking about next steps and what to expect. So kind of wanted to use today to pick your and Doc's brain on that process, how you go about it, and what key takeaways you can give to some of our officers out there.
Yeah, so this is a topic I think that's a little bit of a challenge for most providers, and not that it's particularly difficult, but we just don't. Most providers aren't running, 5-10 cardiac arrests a week. You do it once or twice a month, and maybe you might not do it for a long period between that. So, like everything else, the more you do it, the better you get at it. There's that aspect to it, and then also there's the human aspect to it, right? And it's typically the worst day of somebody's life, and we're there to fill them in on what's going on. So quite the challenge.
You make a great point in the fact that most providers get a couple cardiac arrests a month. Some stations are busier than others in terms of cardiac arrests, but for the 7/8 role, I mean, we've had upwards of you guys running 10 to 12 in a 24-hour period, which is taxing emotionally for sure. So walk us through what it looks like. So obviously you arrive on scene pretty early. Typically you're kind of overseeing and helping guide some of the care on the patient, and then we've come to a point to where we know there's not going to be return to circulation, either based on guideline, or we make the phone call to the docs to get the DC order on that code. Talk us through, as soon as that DC order comes in, what role do you take on that scene?
So I actually like to think of it as the best place to start is a little earlier than that. I like to kind of prep the family early on, whether we are anticipating a ROSC or not. Making contact with the family, I always shake their hand, introduce myself, not as Captain Murphy with the fire department, but as my name is Jesse. I'm a captain with the fire department. Here's what's going on. And get their name. That's really important too. And if you're like me, I have trouble remembering names. I always write it down on my glove. And so that way I can, as I continue to talk with them and liaise with them, I can have that personal aspect. I find that people are able to process things a lot better if it's personal and not so cold. So that's an important thing. And then after I introduce myself, like I said, shake their hand, get their name, I just ask them to tell me what happened. And that helps people process it. It seems to help people process what's going on. And then after that, I let them know what we're doing. It's really important not to use technical terms. It's to keep it as simple as possible. And I think that's one of the challenges that we have, because we are professionals. We know what we're doing. And we want them to know that we're professionals, but the best thing to do is to just use simple terms. So for example, right now your husband, he's not breathing, so we've placed a tube in his mouth and we're breathing for him. We have a device on his chest, and it's causing his heart to contract and continue to circulate blood around his body. So that can be a challenge, I think, just explaining things in a simple ways, but it's important to do that so the family understands. After they tell us what happened, and I tell them what we're doing, I also reassure them, hey, if we were at the hospital and there's a team of physicians, they would be getting the exact same care. So the benefit of us staying here and doing this is that they can have this care immediately right now. After that, I ask them if they have any questions. And I think that's really important to do, to not just overload them with information, but to help them process it. And usually the answer is no. Sometimes they do, but it's important to ask them if they have any questions. And after that, I let them know that I'll be their point of contact. And if they have anything that they want to talk about, if they have any questions, to just come contact me. And usually at that point, people are able to start processing what's going on.
Yeah, I love that thought process, and I think it's important to relay to the family on scene that this is why we're not just running out, taking the person to the hospital, right? I think a lot of people's interpretation of what EMS does is from what they see on TV. A lot of people don't activate 911, so they just see, ambulance crews show up and they take their loved one away, and then they go to the hospital and something happens, right? And I think that's a key point. It's something I used to do too in the 7-8 role, was like everything that they can do in the hospital, we can do right here. So that's why we haven't left yet. And the tube is helping them breathe. We're doing compressions. We're giving them medications to restart their heart. I think that's key information for them, so they know that their family member is getting the best care here, that they don't necessarily have to be at the hospital.
Absolutely. And one of the things that the reason I like to start this conversation early on is I also tell them, hey, if we can get their heart to start, we will take them to the hospital. Which hospital would you like them to go to? You can get a little bit of information for the crews, and then also, if there's hope, you can give them that little bit of hope, and that seems to help them process what's going on.
Good. Doc, in the ED, as a physician, you obviously have to take on this role as well. Tell us some of the key points that you cover when you're talking with families.
I think exactly what Jesse said, I think is the best approach to this. It's difficult, right, to tell loved ones that someone has died. And I think as a provider, at least early on when I was doing this, there's that little bit of internal, did I do everything that I could? Did I do everything right? And then if I tell them they died, are they going to blame me? And there's that fear of blame, that self-reflection that adds into this too, along with the emotional piece and just the difficulty of the situation. And it can be hard. I think one of the best pieces of advice I ever got was people are not going to remember what you say, but they're going to remember how you make them feel. And so those little things of remembering the family member's name or using the patient's name as well, I think goes a really long way. And then just taking that time to narrate what had happened. Sometimes in the hospital, we don't get time to establish that relationship. I think taking advantage of starting early in the resuscitation to develop that relationship and then narrating what's happening is very beneficial, because then if it does come time to deliver the final bad news, you've kind of already set that stage and the expectations, and I think it goes a little bit easier.
Yeah, absolutely. And I think it's important to be honest with the family, right? Especially when you see that we're not going to get a ROSC. At that point, you're usually towards the end of whatever the time frame is for this code. And it's important to touch base with them again before you tell them that their loved one is dead, and just let them know, kind of softening it up for them. So what I like to do is, again, go use their name. Hey, here's what's going on. We still don't see any activity in their heart. We have given them all the medications that we can. We are still breathing for them. We're going to continue trying to get a heartbeat back for several more minutes, 5 to 10 more minutes. After that, if we don't, then we'll likely stop. And so I think it's better to do a phased approach to a notification rather than just all at once at the very end.
I do the same thing when I'm on scene. I'll let them know if I'm there early enough. I let them know that I kind of start with that. Their heart's not beating. They weren't breathing when we got here. We're doing everything to make it restart. And then we try for 30 minutes or 40 minutes, depending on the situation, to kind of plant that seed early so they have a timeline in their head of what to expect. The other thing I feel like, because now you almost have a second patient now, right? And this is your patient. Giving them a chance to tell their story, I think, is very important as well. What happened, because they need a chance to tell that story, right? And then in telling them that what they did before you got there was right. Thank you for calling 911. That was the right decision. Thank you for doing CPR. That gave them the best chance. So kind of alleviating some of that guilt that they're gonna inevitably feel, I think goes a long way too.
Absolutely.
It's a great point. We commonly hear like, well, I wish I would have called sooner, or did I do everything right? And reassuring them that you did the absolute best that you could for them, and that's why we're here. So that's a
Yeah.
great point.
Absolutely.
Worst case scenario for a family, worst case scenario for responders, pediatrics. You have a death notification or you're working a code on a pediatric. These are nuanced cases and they're dynamic. Everyone's going to be different. How do you handle those?
So pediatrics, they're a challenge because they happen so infrequently, and obviously the difference between somebody who's 75 and lived a full life versus 6 months and old and an unexpected death is a lot different scene dynamic. But honestly, I really handle it the same way. Like Dr. Pruitt said, get a patient name so that's personal, and get the parents' names so you speak with them in that manner. And I really handle it the same way to start, and then the end is important to kind of gather everybody around. And honestly, I wish I could say that I had some great advice that these always worked out great, but honestly, at that point, when you gather the whole family, they know at that point, and so I find it's best to just deliver it and let them know, hey, I really am sorry, but your son has died. And at this point, we're going to stop resuscitation efforts. There's nothing left for us to do. And that's usually all that's needed. And then at that point, just depending on the scene dynamic, be there to support them the best you can. And I find usually just not saying anything, but just physically standing there and letting them process it is usually the best thing.
And unfortunately, one of the things we have to think through with all these cases, but peds specifically, is just making sure we're monitoring that scene to something that doesn't look right. There's a potential for non-accidental trauma, abuse, any of those things, like keeping those in the back of your head and knowing when to call for law enforcement early or whatever the decision making is. I think it plays into it as well.
Absolutely, and it's important that we're cognizant of the scene dynamic, right? Is this a suspicious circumstance? If that's the case, obviously, we're not going to let anybody near the patient, whether they're a pediatric or an adult, and we are part of that chain of custody. That being said, if there is no suspicious circumstances, I have no problem allowing the family to come in to say their goodbyes. I think that's really important. If the police are on scene, I always let the family know that hey, at this point we're gonna get our gear out of here. The crew's gonna kind of clean up their stuff. If you'd like to go in and have a moment with your family member, that's fine, but it is going to be the police's decision at that point. And so let them know that's an option. And I've had officers that are fine with it. I've had officers that are not.
One of the common issues we see specific to peds is do we work this on scene or do we go, even if we know it's futile? And I think as a division, what we've kind of spread the message is that the best place for us to provide good quality care is there on scene. So not just arriving, scooping up baby and running out, because we know bumping down the road, at 50 miles an hour with lights and sirens, we're not going to provide the best care. So I think establishing that care on scene is key, doing everything we can. However, if we're getting close to the point where we know it's probably not going to end up in a ROSC, I don't have any issues with us transporting, depending on the scene dynamic, right? Highly emotionally charged, parents, family, people may be upset, and there's a safety concern, I think, for our providers. So I think it's key for our folks to know that our expectation is do everything you can on scene, because that's where the quality care is provided. However, with a PED specifically, if you decide that transporting that patient from that scene is the best course of action, that you're not going to be questioned.
Absolutely. Absolutely. If it's a question of safety, that's what we always, safety first for every scene. These scenes are no different. We don't need to worry about the aspect of, is this a crime scene or is this not? Our provider safety always comes first.
Absolutely. Doc, anything else you want to add?
Just for those pediatric cases, it's actually been studied, like we're there to give patients their best chance at survival, right? And so whether it's a kid or an adult, the science is the same. Those initial actions, the early defibrillation, the early CPR, the early epi or antidysrhythmic is the best chance we're going to give them. And so there's solid evidence that the mortality rates are higher if you just load and go quickly. So doing your best to work on scene at least those initial actions. But of course, if there are safety concerns, then you got to take care of your crew first. But those initial actions, most of these arrests can be worked on scene, and it's better for the patient, even though it's harder sometimes for providers.
Agreed.
Absolutely.
Difficult, but important topic. I really appreciate you both taking the time to come and talk about it. Thank you, Jesse, for the work and you, all the 7/8s and all the crews out there do on these really difficult calls. I know one of the changes we made was having the BLS providers responding to the 9 Bravos. That was a big culture shift for us, but so far we've done a fantastic job of identifying
Great job.
when somebody has signs of life or if they don't, and then making that determination early, calling in for resources if you need them. But I think we've done a really good job on addressing all that. So thank you. All right. That's it for today. If anybody has any interesting cases or topics they want us to discuss, or if you want to come down and discuss, send us an email, give us a call, go through SharePoint, whatever, let us know, and we'll come down and talk about it. Until then, we'll see you next time. Thanks.